Hello and welcome to the webinar, How to Lead Intersectoral Collaboration for Health and Equity in the Context of Limited Resources, organized by the National Collaborating Center for Healthy Public Policy. We are thrilled to have you here with us today. Before we begin, I would like to go over some quick technical details. You will have two ways to communicate and interact during the webinar. You can use the chat to share comments or resources with the presenters and other participants, or for questions directed specifically to the presenters, please use the Q&A option located at the bottom of your screen. We kindly ask that you submit your questions through the Q&A box rather than the chat. We will dedicate the remaining time at the end of the webinar to answering your questions. If you encounter any technical issues, please let us know in the chat and someone from our team will assist you. Please note that the webinar and discussion boxes will be recorded. However, the recording will be stopped during the question period. The webinar recording will be available on the NCC HPP website. After the webinar, you will receive an evaluation form via email. If you have a few minutes, we would greatly appreciate your feedback as it helps us improve future webinars. So thank you in advance. This webinar is presented by the NCC HPP. Our mandate is to support public health actors in Canada in their efforts to develop and promote healthy public policies. If you would like to learn more about us, please look in the chat box to read a brief description of our organization. Before continuing, I would like to make an acknowledgement. I acknowledge that we are on an age-old Indigenous territory, a place of meeting and diplomacy between peoples, and the site of the signing of the Great Peace Treaty. I thank the Kinginkaaga Nation for their hospitality on this unceded territory. So let me outline the plan for today's webinar. We will have three presenters, including myself, Camille Mercier. I've been a scientific at the NCC HPP for nearly 3 years, and I'm particularly interested in intersectoral action for health and equity, as well as in the health in all policies approach. I will begin by giving you a brief introduction to today's topic. Following that, I will present the findings from a literature review that I conducted alongside my colleague Nicole Bernier, which explores intersectoral action for health and equity in the context of budget cuts. With me is Leanne Carley, Senior Policy Lead for the Healthy Public Policy Unit at Vancouver Coastal Health. Leanne has been working for the Health Authority for over 20 years, previously in community development and in population health. Leanne has worked both locally and globally in a variety of topic areas, from refugee settlement to youth development to elephant conservation. She will share her reflections on how to work with others to make positive change in society despite time, money, and organizational, cultural, and structural constraints. Also joining us today is Mathieu Marjolicoeur from the Direction générale de Santé publique at the Ministère de la Santé et des Services sociaux du Québec. With experience in program evaluation, knowledge transfer, and public policy, Mathieu has worked on several large-scale multi-partner projects and teaches at various Quebec universities. He will share his thoughts on the topic of this webinar and key strategies to prioritize. We will also be joined at the end of the webinar for the Q&A period by my colleague Natalia Botero, also a scientific advisor at the NCC HPP. I will start by introducing the topic of this webinar, intersectoral action in the context of limited resources. In this presentation, intersectoral action refers primarily to collaboration between the health sector and other sectors of government or society aimed at improving population health and health equity. This webinar will focus on how such collaboration can be achieved when resources are tight, whether it's limited budgets, time, human resources, or budget cuts. My presentation will focus on the specific context of budget cuts, defined as reductions in spending that a government introduces when establishing its budget in response to economic conditions or political considerations. I will be drawing from the literature on this topic, while my co-presenters will offer practical insights based on their experience in the context of limited resources. So I will be discussing the challenges, opportunities, and strategies associated with cross-sector action in the context of budget cuts, drawing on the findings from the literature review that you see on the screen. Oops. Okay. For context, this literature review builds on the Center's recent work on intersectoral action. During the COVID-19 pandemic, we sought ways to address health inequalities, which were exacerbated during the pandemic, especially as economic challenges loomed in on the horizon. This led us to explore intersectoral action in the context of budget cuts. Given that such action depends on stable fundings and strong public support, budget cuts pose significant challenges. These constraints will inevitably affect those looking to establish or sustain intersectoral initiatives. I will briefly cover the methodology and limitations. For this literature review, we included terms related to budget cuts as well as expression from other fields where intersectoral action is relevant. Our research focused on public health, political science, and public administration within OECD countries. We selected 20 articles for the review, which may account for the broad findings that are not significantly different from those observed in a regular context. However, these results are still valuable for supporting intersectoral action, which is crucial for addressing health determinants and equity. And that is why we have invited my two co-presenters who can provide more insight into the on-the-ground realities of this topic, especially in the broader context of limited resources. So I'm going to present these three dimensions one after the other: challenges, opportunities, and strategies. Intersectoral action is challenging even in favorable conditions, we know, with difficulties well documented, such as divergent interest and the inherent complexity of such initiatives. However, these challenges become more pronounced in the context of budget cuts. Firstly, budget cuts often lead to the preference for familiar solutions over innovative ones. Problems are simplified or centralized, leading to reliance on known solutions rather than exploring new ones. This can result in resistance within organizations involved in intersectoral action, as new demands created by spending cuts can foster risk aversion and inaction. In times of budget cuts, ministries and other sectors may also reduce or withdraw their contribution to cross-sector initiatives, reallocating resources elsewhere. As sectors become protective of their funds, the focus on intersectoral action may wane, with organizations prioritizing their own mandates, leading to more insular attitudes. Despite the challenges, a context of budget cuts can actually foster intersectoral action. Different partners may collaborate to compensate for the lack of resources, optimizing investment, sharing risk, and experimenting with new approaches. This environment can encourage innovation, reduce duplication, and explore synergies across organizational mandates. Take the example of Greater Manchester in England. In 2015, a memorandum of understanding was signed between NHS England, local authorities, and health sponsors to launch the Devolution to Greater Manchester project. What you see on the screen is the health component of the project, the Greater Manchester Integrated Care Partnership. It represents an innovative cross-sectoral effort. And this project aims to integrate healthcare, social services, and health promotion to enhance the well-being of the region's population by efficiently using limited resources and shifting focus from hospital care to community settings. It fosters collaboration among decision makers and professionals across sectors, working together as if they were a single organization. Secondly, budget cuts often resulting from challenging economic conditions can also present an opportunity to address its impact on health and equity. As budget cuts exacerbate health inequalities, it becomes crucial to emphasize the importance of investing in health to boost the economy. Health issues, particularly mental health and inequality, are complex and requires a coordinated effort across sectors. Public health experts should leverage this strategic context to propose realistic, cost-effective intersectoral initiatives to decision makers. By framing initiatives according to the current context, we can seize the opportunity to mitigate adverse effect on impact on health and equity. Our literature review identified 3 strategies to navigate the challenges and opportunities of budget cuts. While these strategies are established in the literature on intersectoral action, their relevance is heightened in the context of budget cuts. First, there's a need to develop a shared vision and readable advocacy efforts with partners and the public. In the context of limited resources and risk aversion, it's crucial to adjust the message to show all collaboration can advance everyone's priorities. To gain commitment, it's not only important to negotiate, but also to respond to and adapt to partners' needs. Additionally, with increased focus on health and equity during budget cuts, it's an opportune moment to raise awareness about these issues and the role partners can play in addressing them. This obviously requires a mandate aligned with advocacy efforts. Forming advocacy coalition can also be advantageous as these groups support initiatives to challenging times. Advocacy coalitions unite actors with shared belief, coordinate action, and mobilize support around political issues. For example, the IAP initiative in South Australia, which faced budget cuts in 2013, benefited from such a coalition. Despite cutbacks, non-health actors who had been sidelined remained enthusiastic about the IAP approach, helping sustain the initiative. Secondly, collaborating with adjacent sector can help mitigate the effect of budget cuts on health and equity. Investment in social protection, such as employment, housing, education, and food security, often have a significant impact on health outcomes. Working with these sectors allows to assess the broader effects of budget cuts on communities and identify actionable insights for partners. Universities and research organizations can be key partners also, especially when public services face cuts to research and evaluation budgets. For instance, in Sheffield, UK, facing similar restrictions, the city engaged 2 local universities in its local strategic partnership. These universities applied their research expertise to address economic, social, and environmental issues, enhancing the overall understanding of the situation. This collaboration benefited both the partnership and the universities, which demonstrated their research impact to government funders and provided valuable employability skills to their students. Finally, partners in intersectoral partnerships should foster creativity to drive necessary innovation in a climate of budget cuts. Diamond and Van Gent suggest creating an environment that supports innovation using the innovation modeling action cycle. These cycles show how intersectoral participants can adopt collaborative behaviors, negotiate flexible processes, and establish conditions that encourage innovation to enable adaptation to the challenging context. Without naming all the points, I'm going to define a few. So clarifying expectation in joint works focuses on collective sense-making during meetings. Instead of just defining objective, it's more effective to negotiate operational processes such as information sharing to establish clear interaction and strengthen participant commitment. Building trust through a common framework involves acknowledging that working across organizational boundaries often starts with low trust. In practice, trust can be gradually developed through low-risk action and modest expectation. And finally, learning from trials, considering cross-cutting issues from new perspective and building solutions based on successes or understanding failures can lead to effective mechanisms for supporting practice change. In conclusion, while budget cuts heighten challenges for intersectoral action, they also offer opportunity to drive innovation and address the health crisis caused by these constraints. By understanding both the challenges and opportunities and adopting appropriate strategies, public health professionals can proactively prepare for and navigate budgetary cuts effectively. So, if you're interested in this subject, you can consult the publication on which this presentation was based, available on the NCC HPP website. I would like now to invite Liane to take control of the PowerPoint and tell us about her experience with limited resources.
Hi, I'm Liane Carley. I'm with Vancouver Coastal Health's Public Policy Unit. And I just want to say that, just as a bit of a disclaimer, the views and my opinions that I'm going to be talking about over the next 15 minutes are purely my own. They may not reflect those of my organization or even those of my own team members. They're just based on 20 years of my own experience working in this realm in various iterations. So really, this is, from my perspective, public health collaborating to create healthy communities. And this is despite time, money, organizational, cultural, and structural constraints, whether or not those structures are within your own organizations or others. And it's always going to be the case. There will never be enough money. Before I do that, I want to acknowledge that I am zooming in from the traditional and unceded territories of the Coast Salish people on the West Coast, including the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I'd like to express my own gratitude for their careful stewardship of these lands that they have watched over and lived on historically and presently. So this is my opinion of how the healthcare system and the bureaucracy in which I work tends to think. So it's very linearly, it's black and white. So you do one thing and it leads to another thing. Somebody's bleeding, you patch them up, they're no longer bleeding. And the results are actually quite predictable and quite good. And that's great. We really do need that in circumstances, and I'm really glad that exists. But it doesn't actually work well for healthy public policy or working in healthy communities. This involves systems change and working on the social determinants of health. And as we know, that is located in other systems, not our own. So you're working with other sectors, so it's not going to be a linear process. And it's definitely not easily predictable. These things don't take place in a lab. They are not controlled environments. It's not easy to predict where they're going to land. While there is some science, there is an art to this. It's a very finessed process that you're leading, and it requires working with a lot of moving parts, and the results are not actually easily replicable because the context in which things are going to take place will constantly be changing. So it's not linear, and they're not conducive to logic models as much as we like them sometimes. This is about working in complexity. This is just normal for working in complexity. And this is an image that's more representative of what it's like to work in complexity. It doesn't mean that if you go down one path and it doesn't go to where you think it's going to go to, that's a failure. That just needs a course correction and it might lead you somewhere else. But it's one of the reasons why cross collaboration can be so difficult. And that's whether it's in a time of constraint or not. So just taking the issue of poverty, for example, there's a lot of moving parts in that. And wouldn't it be great if a brochure could actually solve the issue? That would be super straightforward, but that's not going to be the case. I think within public health, we often think that everybody needs to be involved or everybody at the same time or in the same way, and that's just not the case. So just looking at one issue here would be the mental health crisis that we have in this nation. And we know that within that, the kids are suffering. And one of the indicators within BC where we know that's the case is on the BC Adolescent Health Survey, where in 2023, they rated their health as shockingly bad when it comes to good or excellent. This is what it looked like, though, in 2013. 81% of adolescents in BC self-rated their mental health good or excellent, 81%. By 2018, that was down to 73%. And then just recently in 2023, it was down to 60%. So already we know there's a downward trend, and we probably should have gotten involved in this way sooner than this. But we know that upstream action, especially with children and youth, is going to be the way to go here. And that means, of course, collaborating with others. But when you Google, what do? This is what comes up. So obviously it's everything. And of course it is, because we're working in complexity. So reducing the number of collaborators, that is counter to often what we think is what we need to do, but it's still intersectoral collaboration. Because when you're working in public health, Of course, it's going to require other sectors. That's just how it happens. We can't do anything without working with somebody else. So again, just honing in on that child and youth mental well-being issue. How about zoning into how to create health promoting environments? And within that, why don't we focus in on the school district? So mental health promoting school districts. Now, what are the constraints? Increase in complexity of the mental health issues that schools are having to deal with their students, even as early as kindergarten. Schools are extremely busy. They always have been, they always will be. And they're not experts in mental health issues or even in mental well-being. So where do you start? Within BC, we had an existing window. So about 7 years ago, our Ministry of Education introduced a very vague, but at least it was there, mental health in schools summit and strategy. So they had this summit as a start to launch this strategy. But the thing is that we were not invited as public health. So we had to get at the table. The people who they did invite were our mental health counselors. So they're very downstream in that invitation. So we had to get at the table as public health. And I'll tell you at the beginning, we did it guerrilla style. We just showed up. And we did that because we wanted to make the connection with school districts and change their concept of who health was and what we could do. After that summit, we didn't immediately jump into that relationship building. We wanted to respect school district time. We wanted to get our own ducks in a row with this. So we held a meeting of inquiry. How is the health sector in the region helping to strengthen mental well-being in schools in partnership with the school district? And as a group, we came to the conclusion that we could do better. So we didn't want to leave it on the school districts to nurture the relationship with us. We went to them. And our window there was the school district's mental health in school strategy. It wasn't very well developed at the time, but what we offered at the beginning anyways was to look at their documents. And they actually asked us, how do you see yourselves within our strategy? So we had to be clear about what we had to offer. And so we went through their documents and we looked at where did we see ourselves. And as we were acting as one, there were several public health teams involved in this. And outsiders see us as one, and so we need to start acting as one. It's a lot of work for them to figure out who we are and what we do. So you have to demonstrate and be helpful. That's what they're looking for, value add. They're not just looking for you to be sitting in their meetings. That's what builds the relationship with which opens up opportunities. Again, regardless of how much money or time is involved, it's about the relationship. And at the beginning, we offered a little bit of money and it wasn't that much and it can unlock a lot of potential. So at about $7,000 at the beginning to encourage the school district to participate in collecting data through the Middle Development Instrument, which is done by many school districts in the province of BC, but in this particular school district that we were working with, it was not. And they started doing it just based on that encouragement and that money, as well as our offer to lead some data sessions so they could make use of the data and to facilitate discussions for administrators. And that one time, which was done in 2007, 2008, they then started doing it on their own on a regular basis. That's all it takes sometimes. We're also using this opportunity to build this. We are now actually part of their school district mental health in schools committee, and it's just us at the table with them. That's how much we've built that relationship. And we're their connection to other things. So for example, BC Children's is doing a webinar series for parents that will weave into mental well-being. And the school district has offered some input into that based on our connection with BC Children's, because again, we're all health. Expanding the web is also part of this collaboration, so enabling connections with others who are working with the school district. We held data sessions with our own public health nurses who work with schools, also data and facilitated discussion with multifactorial tables who work with school district, and making the conceptual connection and the physical connection to other initiatives such as the Youth Climate Corps with the school district, since that feeds into climate anxiety and therefore into their mental health and school strategy. And then helping to activate other sectors such as local governments. So even something like activating their school active transportation within their master transportation plan with the local government, as well as creating local government guides on how they can support the mental well-being of children and youth. We're doing a specific play workshop with the local government, and we're looking at how to help local governments weave children and youth into social development plans. So all of this is going to support and grow the collaboration with the school districts. And in the future, we'll probably be leading a community audit, so a community-wide audit using PHAC's positive mental health indicators with a small group at first, but again, all sectors at this point. So you can see how we've grown from a small collaboration into a big one. And again, this is despite constraints in time and money. This is my final example, and it's about basically if you're going to do a multisectoral collaboration from the get-go and you're leading it, you have to put a lot of work into it. You have to articulate expectations and link it with other similar initiatives and collaborations. So that first example was us getting at the table. This one is getting others to the table. So focusing in on active transportation. Again, our window of opportunity was kids, but it was going to take a lot of sectors in this one. So not just local governments and more than one, but the regional government as well, the school district, the district parent advisory council, NGOs, the Ministry of Transportation and Infrastructure, the Transit Authority, the RCMP, and then health, and beyond the health authority, the divisions of family practice. So before I would even do that, I met with them individually first to see if they even saw themselves in this picture and what their interest would be about getting together. The challenge, of course, was going to be different sectors focused on different age groups, different mandates, some no direct link to active transportation. So for example, the RCMP, no direct link, but could they do things to enable it or disable it? They sure could. Not a lot of time, not a lot of money, and then competing priorities. Again, put a lot of work into it, articulate your expectations. Do your homework. That was part about meeting with them individually first. Design the gatherings. That takes a lot of work, but you don't want to waste anybody's time. So know where you want people to land after a meeting. That doesn't mean that it's rigid and no flexibility in it, but you want to make sure that when people leave every meeting that you hold, they think that that was a good use of their time. You have to ground it in a collective and a custom why. So what's in it for them? What's in it for their organization? But why is this even important? If there's no compelling why, they may come to a first meeting, but they are not going to stay. So that first meeting where I held them together was really about, is there even buy-in? So I presented some of the data, but data isn't going to be enough on this one. There has to be a more compelling why to ground this in. So was there even a desire? Did they see this as important and in need of improvement in their geographic area? And if yes, I don't do this lightly, but I was willing to lead it. However, I did have some expectations and I told them so. And the expectations were, if you say you're going to do something, do it. And you're holding yourself accountable. So I'm not going to come in and chase after people. It's about self-accountability. I've never had a standard meeting agenda. So each meeting is truly designed to build off the previous meeting. And then there were some opportunities to learn, but I was never going to have a meeting where it was just somebody else presenting on something. I never needed anyone to prepare anything to attend. However, there was a gentle shift so that over time, the meetings put the spotlight on the people who were attending to articulate what they have changed, to articulate their sticking points, and to tell others around the table what they needed from them to either do or stop doing. So it really wasn't about us collaborating for a product, a single product. It was initiating action within their own sectors and organizations, preferably in a complementary way to what others were doing and in an intersecting way. So for example, the school district changed their student transportation policy. Before it was just about buses, and they wove in active transportation. The district PAC passed a motion that they would be supporting active transportation, and they brought that to the provincial level so that all DPACs across the province would be supporting active transportation to school. One of the regional governments were working on their master transportation plan, and they intentionally and strategically including children and youth in that. Within the regional growth strategy, they too wove in active transportation modes and children and youth. And there was a highway safety study done by the Ministry of Transportation, and they intentionally included children and youth, and that is woven throughout that study. So again, you're linking it with other similar initiatives and collaborations. That's what makes this get stronger. So for example, TransLink, which is a regional transit authority within the Metro Vancouver area, which is not where this initiative was taking place. We invited this local organization and the actors within it to these meetings to learn about indicators and existing materials and resources they could tap into. We tied this into the BC injury prevention to strengthen their relationship with the Ministry of Transportation in other departments. We worked directly with the Ministry of Transportation on their active transportation strategy to strengthen it. That would then strengthen this local initiative. We presented to the BC Healthy Child Development Alliance on children's independent mobility and building that confidence and competence in the early years. And then we looked at data sources and trying to get everybody to use ones that are existing and good so that we're all talking about and reporting about on the same things. So for this group at the local level, it was important to articulate the impact, and you're doing that as public health for them because they don't have time to see the success, and success isn't always obvious, so you got to point it out for them. Products are important, so that student transportation policy, yes, a win, but you have to recognize the process is equally as important, and shifting is normal and expected. So at the beginning, this group wasn't about working on one thing together. It was about getting them to do actions within their organizations and their own mandates. But then they got to a point where they wanted to work on something collectively together. Actually, that's a win, and that's a shift. So just some of my parting thoughts here are the more complex the issue that you're trying to change, the more iterative a process that you have to take and to take within constant shifts. Understand and identify what impact actually looks like when you're public health working in the healthy public policy realm. And sometimes the process is the change maker, not one collectively made product. And on to Matthew.
Bonjour, attendez un instant, je vais... Bonjour, hi everyone. First, I will ask you to excuse my English. I don't work very frequently in English, so that's it. And second, I would like to start by recognizing that I'm in Montreal, which is the land of an indigenous territory of the Ghanaian Gehaga, the keeper of the land and the water. So Montreal or Doja Gay have been a place of gathering since a long time for many First Nation. And as we know, well, Indigenous people experience significant disparity compared to non-native in terms of health determinant, state of health, and access to care. These inequalities are the consequence of colonial policies and practice that have set up different problems as intergenerational trauma, erosion of cultural identity, and severe economic and social marginalization. So I want to make place for that thinking first. Thank you very much, Leanne, for these clever and concrete insight that you gave us. And I'll have to make maybe a point a little bit higher. So first thing I would like to say that I have a thought about the relevance of this topic, the importance of that topic. As we know, there is a lot of changing in the public health field, and so the importance of a reflection on intersectoral action, and also at the time scale as it is in period of austerity or limitation on resource is pretty important. We have growth and recession cycle in your economy, and mostly government choose to work in that path instead of different priority. There's also a reflection. Well, all the work that have been done and show a pretty good way to have resilience as a system, as people that are working on different domain, as we can see with the presentation of Leanne. And well, also it's important to say that since the COVID-19, well, public health is pretty on the radar now, and it's this awareness from the public give us great opportunity to make new stand with new partner. The other thing, well, it's sure that as there's a lot of different literature that says that the work that we have done is not the same as the work that we will have to do. As for example, well, maybe that we will not be able to have the great life expectancies accomplishment that we had in the last 50 years. But if there is place for better life expectancy, it might be with social inequality, or maybe it's something else that we have to work on. So that's why we change a bit some of the concern. There's a lot of talk about structural determinant of health more than social determinant of health, and now I hear most very often commercial determinant of health. So, and that's bring us with a clear a clear opponent there, and that can be difficult to work with. And so all these new way of doing that we can see forward us place us not in our office, not in our behind our computer. We will also be behind our computer, but we have to work with partner, and that's mostly what I've heard from Leanne. It's like you have to go with people, you have to be there when they are talking on a topic, and not exactly just looking for funding. And when you work on structural determinant of health, well, maybe the other part of the the partner that you will have might also look for funding. They will be in constraint, in large constraint also. And well, last first thought on it's always fine to have this kind of conversation, because instead of just tinkering or breaking through and just having to a way to solve a problem, we can maybe build a better vision of what we are as an institution, and develop also way of doing things. So have a real insight of what work when you work with others. So that's pretty good. I have one of a colleague that's always thinking about system boundary, and for public health that's kind of an issue, because boundary can be very large. We want to go on every turf of our field about everyone, but if we can not think of a system, thinking in a way of a system, I'm public health, but more thinking in a network of partner. Well, you change the mentality, you change the paradigm, and you might have real success there. There's also, as I said about the boundary, other people are interested in the boundary, in the public health domain. They want our information, they want or how you say that, knowledge, and they ask for it. And so that perspective is very important in the society. It's almost always always the second topic, the priority topic on the population. So it's pretty important to have this place where maybe we're not on our field, on our turf, but we are on the other turf, so we can use their language. That's a very important message to see, to use their language instead of always being on our language and our way of doing of telling things. So just a minute, I have some difficulty of going through the diapositive there. Okay, so working with in partnership, some lean reflection on that. First, well, it's important, and Leanne have the same idea, to develop and promote strategic partnerships. So instead of doing lots of people, maybe getting the right person, try to find and getting to work with the right person. That's kind of a big idea that is very important in my sense. So for that partnership, we'll see a little bit further on in the presentation that there's a way to do it, like if first starting by a mapping of your partner and or the actors that are involved in one domain, in one topic. Explore new partnership. Hey, so that's kind of a problem. There's partnership that have been always there in public health, but still aren't working as well as it should be, like a university. Well, I'm not very familiar with other sector or other province in Canada, but in Quebec, there's a lot of good work doing in university, but the junction between public health and university is not that simple. Philanthropy, well, there's lots of different ethic question in the working and the collaboration with the philanthropy. So that's a part of a real issue there. Well, and second idea, it's having a structure, a framework of governance. If you can establish a governance framework to ensure the trust and collaboration between the partner, that's a real great importance, and that's in the same sense as the first presentation of Camille there, and maybe, well, if you have this kind of framework, well, you can have in that framework the allocation of resource, which might not be just money. Resource can be people, can be leadership, can be involvement, can be voluntariat, or there's different way of giving resources. So that can be very important. And well, the last part of it, and I think that's another great message, involve the population. So or narrative, or way of thinking, or what we say is important, what the population want and say is of more importance in my view. So it's very important to have this. Whoops, I think I just skip a slide there. I can go back. Yeah. Well, I don't have that much time, so I might just skip to this one. If we want to have time for the discussion and the question, the Q&A. No, you can just put it on the other side. Yeah, please. Thank you. So in that reflection, it's important for me to say that there's something that are very great in the public health domain, and something that we still have to work on it, I would say. So the thing that is very important, and this is part of our success in each time that we have success, that's mostly because of these characteristics, is that we have an evidence-based approach. We know data, we know what are evidence, we know the data at the local level, the population level. So and we know what will be the benefit for the society to get in line with our intervention. So this is very nice, and we have to keep that in mind, and we have to keep a lot of resource in that endeavor for these highly quality information that we give to people in a project sense, and in the collaborative or intersectoral approach. We can also make evaluation. That's one of our technology. So the evaluation, the program evaluation. So we have to use that for evaluate the intervention, the collaborative intervention that we have. What we don't, where we're not that good is on prioritizing. That's really something that we have to be better with that. As well, Leanne have give us really great insight on two different projects, but what we can find here is that it takes time, but if it takes time, we don't have that much resource. We have to choose which of the resource will be put on what intervention, and that asks us to look at our intervention and find which of them are of high impact intervention. So this is a part of the work that we have to do, and this is a great starting point. I don't know which one I have the. Yep. Finally, no, just the last. Thank you very much. I think it's Martin. So three final piece for the discussion. First, well, as I told first, there's a real issue on finding the strategic partner, and for that, well, we need to better understanding the environment and the different actors that are in line in our topic. So a political radar, a matrix of a cartography, a mapping of the actor. These are all important first step to be done on these kind of intervention. Use argument that will be understood by the different partner. This is very important. That's why I ask for intervention or integration of the population in our endeavor. These are the language, the message that will fit better the people. And well, there's some place where we don't have that much of knowledge. It's maybe on the economic benefit of the intervention that we deliver. So the voice of the people, and maybe find new knowledge on things that where we are not that good. The economic benefit is one of them. And well, in the last part, well, it's choosing the right priority. It's the same thing as the other slide. So prioritizing and choose the action where we can have better insight and have success. So I think that's all for myself.
Thank you, Mathieu. Thank you for this interesting, very interesting presentation. Before we move on to the question period and stop the recording, I would like to express my gratitude to my co-presenters, Leanne and Mathieu, for their valuable insights. For those who need to leave, thank you all for your attention and participation. If you're interested in this subject, the NCC HPP offers several publications on intersectoral action. And also, please remember to complete the evaluation form that will be sent to you after the webinar. So thank you and see you soon.